afternoon, and thank you for joining us today. Today we are going over the CPH exam review for health equity, social justice, and the application of theory. My name is Erin Williams, and I work with the Association of Schools of Programs of Public Health, which are sponsoring these CPH review webinars. I'm sure most of you know what the CPH is, and you're familiar with it. The CPH is a great way for you to professionalize what you are doing in the role of public health. It shows that your dedication to the field of public health. It shows your commitment to continued learning and education, and we are so pleased that you have decided to study and take your CPH exam. There are a few resources that we have developed that we would like to share with you today in addition to these webinars. Each of these resources can be found on the NBPHE website, nbphe.org/cph-study-resources, and you can go there and get links to all of these resources that I'm about to talk about. The first thing we have is the content outline, and this is what we suggest that candidates start reviewing the content outline, determining which of the topics that are outlined here seem familiar and which do not. And then with each of these content areas, there's going to be a list of identified job tasks outlining the skill set required within each of these content areas. And this is a great way for you to determine what you're most familiar with and where you need to start studying. Also on the NBPHE website are some sample questions in the format of the CPH exam. So you can see all of the questions are going to be multiple choice, single best answer. There are no fill in the blank answers. There are no open-ended response questions. Everything is multiple choice, single best answer. We also have some free practice exams on the NBPHE website. There is a 50-question exam, and these are items of retired questions from the actual exam. You can take this practice exam as many times as you want, and each time you'll receive a detailed report with the results. And this is a great way for you to kind of determine where you stand and where you need to focus your studying for the actual exam. Another resource is the ASPPH CPH study guide. Now this is what we have developed. Excuse me. Oh, excuse me, let me start back here. We do have more upcoming webinars, lecture and question and answer. Next week we have planning and evaluation and collaboration and partnerships. On the 28th we have public health systems, history and leadership. We then have public health law on September 10th and health policy process on September 17th. And then lastly, public health biology and human disease risk on September 27th. We are also in the process of adding a specific biostatistics webinar that will elaborate on the evidence-based approaches webinar that we've already given. And these and all past webinars and presentations will be posted on NBPHE CPH-study-resources. Now let's talk about the ASPPH CPH study guide. This was developed by ASPPH. It's available on cphstudyguide.asppph.org. This is going to be an interactive practice exam type study experience. It is not text-based. It is not a book per se. I'll get to that in a second. But it is a database of over 400 questions developed by public health item writers. These are not actual live questions from the exam, but these are very similar to what you will see and is taken directly from the content outline, and each question will task to one of those skill sets required within the content area. You're going to get a unique exam every time you take it. You'll receive immediate results, and then within each question, there will be a detailed explanation of why that is the correct answer, as well as links to different resources that you can click through to get further information if that is an area that you've determined that you need to study. And then lastly, we have the APHA Press Study Guide, which we recommend. This was written by our faculty at the University of South Florida College of Public Health. Most of the webinar presenters that are speaking with you all this fall are from USF, including our esteemed presenter today. It is a great, comprehensive all-in-one book that covers all of the content areas and really goes into detail if you need that in-depth text-based study prep. And you can purchase that directly from APHA Press. And now let's get started. Right before I turn it over, I want to indicate that you will see an orange box with a white arrow. If you click on that, that's going to open up your GoToMeeting webinar control box. Here you'll be able to see a question box, and in that question box, you can feel free to type any questions as you're going along. You can, if there's something that is just general, I'm going to be moderating that and I will be answering as we go. And if it's a question that you would like our presenter to speak more about at the end, if there is time, then I will read those at the end and we will go through as many as we can. If there's any questions that have been presented that we do not have time to answer, we can follow up with an email afterwards. So please feel free to utilize that question box. And again, this webinar will be recorded and posted on the website as soon as possible, along with our PowerPoint presentation. And if you would like to access the PowerPoint presentation now to go along and take notes with, I have posted it on the NBPHE website, so you can access that now if that is something that you prefer to do. So without further ado, I would like to turn it over to our presenter today. I would like to introduce Anna Torrens Armstrong from the University of South Florida College of Public Health. Anna, thank you so much for joining us today. The presentation is now yours.
All righty, thank you so much for the introduction and the overview of kind of the exam. I'm very happy to be here today to provide this exam review for you on the topic of health equity, social justice, and the application of theory. So just to give you an overview of some of the things we'll be talking about today, let's see, my slides are not advancing. Let me try it one more time. Erin, it doesn't seem that I'm controlling the slides. Let's see. There it goes. Okay, just to give you some overview of the topics, kind of the areas we'll be talking over for the next, I'm going to shoot for an hour and a half. We have 2 hours. I want to make sure to leave time for questions. And just a reminder, as we go through this information, I'll be moving quickly, but remember to take notes. If you haven't downloaded the presentation slides to take notes on, please have something open that you can write down some comments, some of your ideas. As we go through this information, you might have questions, so jot those down. All of this process of taking notes is really helpful when you're preparing for an exam of any kind, because just the process of note-taking will aid in your ability to recall information as you prepare for the exam and actually sit for the exam. So I'd like to start with a question just to kind of see where everybody is in their CPH journey. So if you take a look at this question, where would you consider yourself in your journey to prepare for the CPH exam? And your options are not ready or not intending to be ready for the next 6 months, but I'm here, so there's that. Or B, not quite ready, but thinking about registering to take the exam in the next 6 months. C, you're registered and preparing to take the exam in the next 60 days. Or D, you're registered and have been prepping to take the exam in less than 30 days. So this will take us to a live poll. There it is. Okay, so looking at what we have is that we have some people who aren't quite ready, but it looks like everybody is in either contemplation, preparation, or you're about ready to take action. So you'll hear this again. It's actually using a theoretical framework, so I thought it was relevant to frame the question this way. But I'm glad you're here, so this lets me know that you're almost ready. You're in the process. So moving on to the next question. Where are you? Where would you place yourself in terms of your public health experience? So we have a couple of options here. You're either working on your degree, you have a brand spanking new degree that's hot off the press, you've been in the field 5 years or less, or 5 to 10 years or more, or 10 to 20 years, or 20 plus years, or maybe there's something I'm missing that doesn't capture where you are in your public health career. So we have this next poll for you to respond to. Okay, so it looks like we have quite a few brand new public health professionals or people who are working on their degrees, and then we've got a few people who've got quite a bit of experience that are now taking the CPH exam or considering it, preparing for it. So that is helpful as well. So some of you, this information might be fresh because you're either currently in a program or you just finished a program, and so it's a good review. Some of you may have not seen this information in many years, and so therefore it's a great review for you as well. So we're going to go ahead and just jump in and get started. And what I'm really going to start with is kind of the big picture. The slides still aren't going forward. Let's see. There we go. So when you think of public health and major public health threats, what is the one thing, and this is just a rhetorical question, what is the one thing that they all have in common and that is really a defining feature of public health? So I'll let you think about that just for a split second. And I know that many of you probably are already saying or thinking to yourself, there are things that are largely preventable. In public health, we aim to understand the threats in our communities, in our environments, and as well as the behaviors in order to develop interventions to reduce preventable morbidity and mortality. So we're really looking at prevention in public health. And a good place to start as a foundation for this particular webinar, there seems to be a little hesitation maybe in my slides. There's the next one. In order to really grasp what public health does is to take a look at the Healthy People 2020 overarching goals, because they really highlight the complexities of prevention and health promotion while emphasizing health equity, health disparities, and the importance of the social determinants of health. So to begin to think about health equity and social justice, we first have to define some key concepts and discuss that there has been a shift in public health toward addressing the root causes of health disparities in our nation and globally. So how do we do this? How do we address root causes, at least tangentially? We have to address health disparities and use public health theories to guide the development of effective and efficient programs to help combat these conditions. We have to ensure that these programs and services that we develop are linguistically appropriate and culturally competent. These are the things that are vital to achieving these goals. So we'll review each of these concepts a little bit more, but first, let's talk about population health. So when we talk about population health, I want you to just take a second and jot down some notes to yourself by what does population health mean to you when you hear the terms population health. And you have some images in front that might give you some ideas. But when we talk about the mission of public health, we are talking about fulfilling society's interest in assuring conditions in which people can be healthy. So population health uses a population-based approach to understand and address health outcomes. This means an ecological approach. So on the left-hand side of your screen, you see a social ecological model. And that helps us understand the complexity of the factors that influence health, and as well as a systems approach. It gives us that systems approach to address that complexity. It also means collaboration across multiple disciplines with a focus on the population as a whole, as opposed to focusing on individuals at the client or patient level. So we think big picture. The population-based approach is a hallmark of public health. It's multidisciplinary, it's collaboration with the goal of health for all. So this is an important thing to note. When you think, what are some examples of the things we know are occurring in public health that reflect this idea of a population-based approach? So I want you to think just for a few minutes, jot down some of your ideas, and I'll give you a few examples. So I'm hoping that some of you have already thought about vaccinations. So eradicating life-threatening diseases, measles, smallpox, polio, through the use of vaccinations is a very clear example of a population-based approach. Reducing death and disability due to unintentional injuries through policy designed to protect the safety of the public. Things like bicycle helmet laws, seatbelt laws are another way that we use a population-based approach. So thinking about policies. The assurance of safe water, the assurance of a clean environment through regulatory enforcement of regulatory controls, provision of regulatory controls, and management of hazardous waste. Controlling and preventing infectious disease outbreaks. These are just a few of the examples that we can clearly identify as a population-based approach reflective of the mission of public health. So I want to tie this back to one of our essential tools that we have in what we call our public health tool belt, and that's the career field of epidemiology and its focus on population assessment. So it's really important to think about, where does epidemiology fit within the larger context and why is it important? So I've given you the definition here on the screen. You can read for yourself of kind of a refresher, what is epidemiology? And why is this tool in our tool belt so important? And it's that when it comes to deciding where and what to focus our energy on in the field, epidemiology paired with biostatistics will provide us with the direction of which way to look and where to start. It gives us the magnitude, the person, the place, and the time. And this is a critical tool for us when we think about population health and studying a population-based approach. So public health, one of our main foundations is social justice. And it is, I would describe it as an inherent value to what we do. We often will see a debate within public health over personal rights versus public safety and just public health in general. It's in the news almost daily. So this social justice foundation has always has public health considering measures that aim for achieving health for all as a fundamental right. Something happened to my slides. There they go. So again, thinking about just some of the examples I just gave, here you see some ads for covering your cough, click it or ticket, community gardens. So again, just trying to reiterate what health for all looks like, and that the idea is over personal rights, personal responsibility is when is it of value for the population as a whole. So building on the idea of this foundation of social justice, I like to share the following image. There we go, of this tree. So this is a good place to take some notes because the definition is not on this slide, but I am going to give you the definition for social justice. And when I think about social justice, I look at this, and a good reference to just further enhance your understanding. A great, there's an article written about this, but there's also some TED Talks done by Dr. Kamara Jones called The Gardener's Tale. So if you just look up Gardener's Tale, TED Talks, you'll find her talk. And she kind of uses the same idea. It's an allegory, but the tree is, you know, our society and the people in our community, and all of that underneath the soil that feeds the roots is really this idea of social justice. So social justice is defined, here's where I want you to take notes, as justice in terms of the distribution of wealth, opportunities, and privileges within a society. It's the view that everyone deserves equal rights and opportunities, which includes the right to good health. So we need to, that social justice, again, is that foundation for public health and the inherent values that we have. If we want justice, if we want our tree or society to be strong, we need to make sure everyone has the right foundation or soil and has equitable access to that soil. So to take this a step further, we talk about health equity. And so I want you to keep taking notes here. There's a bit of a definition here for you, but health equity is a term that we use in public health to describe the application of the principles of social justice to health. And so when we look for health, the U.S. Department of Health and Human Services defined health equity as the attainment of the highest level of health for all people. Specifically, when we talk about health equity, we talk about it relating to fairness and ensuring that no one is denied the opportunity to be healthy. So in this image you see in front of you, it is giving you this idea that when we are trying to reduce our health disparities, one of the things we're trying to do is increase health equity. And sometimes that means that you need that extra stepping stone or that extra boost, which is that program or a policy that's designed to help make sure everybody has equitable access. So just to summarize the concept here, health equity is the application of the principle of social justice when we talk about health disparities. And how I think about this that's very helpful is that I think of health disparities as symptoms of the social determinants of health. And we'll talk about social determinants of health soon. These symptoms, health disparities, are created by a lack of social justice. So we know that health disparities are not great. They're prevalent, and we have them, you know, across different populations. And we'll talk a little bit more about that. But why do we measure health disparities? Why are we collecting data around health disparities? So we'll go to the next slide. And really, one of the reasons we measure health disparities is to see where we are and to be able to track our progress in decreasing health disparities. So we use health disparities as a metric. And this is another slide that's really important information. So jot your notes. What are health disparities specifically? When we define them, they are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Additionally, when we talk about health disparities, some populations we know experience health disparities at much higher rates than others. And there's some examples on the screen for you. And this can be seen by race or ethnicity, gender, education, income, disability, your geographic location, whether you're rural or urban, or even within an urban municipality, even sexual and gender identity, we see health disparities. So why do we need to measure them? Because we really need to understand how are we making progress in addressing these health disparities? How do we measure them? This is why I mentioned epidemiology earlier, and hopefully you got to see the epidemiology webinar. We look at birth rate, we look at infant mortality rate, we look at morbidity and mortality and cause-specific mortality. We want to see if we're making progress in addressing these disparities. It also helps us direct where we put our efforts, where we place our efforts in terms of programs, interventions, and policies as well. And we can also use theory, so we'll get to theory in a little bit, but we also use theory to really understand and create a very clear clinical picture of what is happening that leads to some of the health disparities we see. So I mentioned the social determinants of health, and really we look at social determinants of health as a major driver behind our systemic public health issues. They are not easy to solve. It's not simple by any means, but it includes, but it is not limited to socioeconomic status, transportation, housing, access to services, and as well as discrimination by social grouping or social and environmental stressors. So I've got some examples here for you to take a look at to help you kind of lock that into your memory. You see on the right-hand side the map, and this is from the District of Columbia, and you can see Washington, D.C., that the difference in lifespan by metro stops. This was a study with the Robert Wood Johnson Foundation. So I think, and this is the little images across the top, and this is what you'll hear over and over to remember, what are the social determinants of health? Why are they important? It's where we live, it's where we work, it's where we pray, and it's where we learn. So our communities, our workplaces, our schools, our parks, all of those things have an impact on our health and in determining our health outcomes in terms of longevity, morbidity, and so on. So remember, health disparities are like a symptom of the social determinants of health, but they also, when we look at health disparities, we can use those as a way to measure improvement in health disparities, and thus maybe we are slowly moving the needle in terms of improving our social determinants of health. So I have an example for you to just briefly look at on the next slide of how we use upstream versus and how it impacts downstream. So if you start on the left-hand side, you can see examples of what we've referred to as upstream interventions, which lead to health equity. So that's why I'm showing it, is just to give you an example of what do interventions look like? What do they, what do they do if we are trying to really chip away at the social determinants of health and improve health equity and decrease health disparities? So looking at something like policy revised to make drugs affordable and accessible. So the upstream idea here is health policy. And if you look downstream, what happens if we only focus on the patient or the individual? It still creates a social gradient. So upstream is always where we want to try to target our efforts. Universal health insurance really will take the focus off of the patient and is a more system-wide impact. Providing clean water and sanitation for all, as opposed to putting the burden on the individual to have their own personal water filters or water systems. I like this one because it's a pretty clear example, since we do have clean water for the most part. If we said, no, we're not going to do clean water anymore, and everybody in the country has to get their own personal water filtration system, there is a social gradient that's going to occur quite quickly because those types of systems are not easily accessible or affordable. So that's just an example for you as you consider and think about, how does this look like? How would you identify an example of upstream versus downstream in relation to health equity? Next, we're going to talk about cultural competence. Oh, and there's my little circle that showed up. Okay. Cultural competence is one of the most effective ways to improve health equity and close the gap on health disparities. It's something that's focused on the system. So a place to take notes here, here's the definition. One definition, anyhow, of cultural competence is understanding and appropriately responding to the unique combination of cultural variables and the full range of dimensions of diversity that the professional and client, patient, family bring to interactions. One way that we try to address cultural competency is by assuring that healthcare services are provided in a culturally sensitive and linguistically appropriate manner. So when we do this, It helps our public health professionals improve health equity. Cultural competence, what it does is promote the need for programs and initiatives that meet people where they are, with interventions that are linguistically appropriate and culturally sensitive. And we want programs that embody the community voice, are inclusive of other strategies that also have the potential to influence social determinants of health, like housing, safety, or education. And lastly, to ensure a platform for long-term sustainability and continuity of services for the full spectrum of care, from prevention to early detection, treatment, and evaluation. And another element of this that's very important is health literacy. And also, how do we infuse health literacy as a part of the system, as opposed to placing the burden on the individual or patient? Okay, so we have a vignette here for you to start with. So I'm gonna go ahead and read this out loud. And we'll have some questions afterwards for you to respond to. So Esperanza is a 35-year-old female living in Buenos Aires, Argentina, in an area known as Villa Miseria, an overcrowded slum near Buenos Aires. There is no sanitation system, and the electrical power is not always consistent. Approximately a mile away is the vibrant city of Buenos Aires. The health and economic disparities between these two areas are glaring. Esperanza does not have access to the same services as a mother living in Buenos Aires and is 35% more likely to die in childbirth than a mother in Buenos Aires. So we'll take a look at question number 1. To improve health outcomes in Villa Miseria, which of the following principles would be helpful? A, health determinism, B, social justice, C, epidemiologic studies, or D, the Transtheoretical model. And here's your live poll question. Okay, so the majority of people got this question correct. The answer was social justice. So 84% of our respondents selected social justice. Just to give you an idea, the letter D, the Transtheoretical model, was just thrown in, so it wasn't an actual option. So social justice embodies the principles of equity. So remember this: equity and access for all. So by addressing these inequities, we can help to improve health and ensure access for those in need. The other choices don't apply. One, we didn't talk about health determinism. And epidemiologic studies might help to understand the issue of death during childbirth and maternal outcomes in terms of postpartum outcomes. But really what we're looking for was social justice in this question. So let's take a look at the next question. The single best predictor of poor health, and that's a typo, is in Esperanza's community as well as in society as in general, is A, poverty, B, race, C, religion, or D, gender. And here's your poll to respond to. Okay, so the correct answer was A. The majority of you responded A, poverty. It is the single best indicator of health. So it's a proxy, but socioeconomic status, which is tied closely to class as well, and places where they use that as a definer or descriptor. Simply those at the top have more and better access to resources, more power and control, and on average live longer, healthier lives. The other responses are important, but what we know from our studies and all of the data that's available is that the single best predictor is poverty. Okay, we have another question. Let's see, but these questions will not have a live poll, so I'll just stop and let you pick your own answer, and then I'll wait a few seconds and give you what the answer is. So I'll read this question for you. A public health team was interested in assisting in Villa Miseria to address concerns with water and sanitation. They seek to do so in a culturally appropriate way. Which of the following is the best example of culturally appropriate community engagement and empowerment strategies? A is providing health services and implementing programs that have proven to be successful in communities that are culturally distinct from the focus community. B is avoiding bias by developing programs prior to meeting with community leaders and investigating the specific needs of the community. C is choosing interventions that have previously been applied in the community by local and national political leaders. And D is implementing health projects that result in the reciprocal transfer of knowledge and skills among all collaborators and partners. So take a few seconds here to decide which is your best response. Okay, so if you selected D, you selected the correct response, or the best response. I like to refer to it as the best response. Implementing health projects that result in the reciprocal transfer of knowledge and skills among collaborators and partners is imperative to ensure success and sustainability. What it does is places the community in a position of power where their voices are being heard. And while including community partners in implementing programs with a proven track record can be important, simply translating language is not enough. Additionally, the community should always be included in every step of development and implementation in order to ensure success. So our next question. A stakeholder in the proposed water and sanitation program is best described as A, anyone involved in the operations or affected by the program in Villa Miseria. B, the beneficiaries and participants in the program. C, the sponsors and administrators of the program. Or D, the financial investors in the program. So take a second to select your best answer. And if you selected A, you are correct. Stakeholders can be anyone involved with or affected by a program. So this can include the recipients of the program, the surrounding communities, the providers that are involved, and those who operate the program. So I always think of a stakeholder as somebody who has some stake. Doesn't matter what the stake is, they have a stake in the program. And so therefore they should be involved to some extent. Okay, and I think this is our last question. The biological, environmental, behavioral, organizational, political, and social factors that are contributing to health in Villa Miseria are commonly referred to as A, social justice, B, determinants of health, C, health behaviors, or D, causal factors. So the answer for this question is B, determinants of health. The biological, environmental, behavioral, organizational, political, and social factors are what we refer to as determinants of health, and the other choices don't apply in this question. So that's why we would select B as our answer. All right, so now we're going to shift gears, and I actually have a little more than 30 minutes based on how we've moved through the first part of the presentation. But I try to do this in 30 minutes or less, but it never works. So here's for hoping and wishing. Theory is a critical component of public health. We use theoretical frameworks to improve health. Public health programming, what we know, is most effective when it addresses multiple systems level factors. So thinking individual, organizational, community. And this is where public health theories are most useful. We use them to inform our public health programs and interventions. Theories also help us to understand health issues, risk factors, behaviors, and also create the programs and interventions. So theories are quite powerful. So we're on this, I didn't mean to advance to this slide just yet, but we're here now. Just a little bit of images to get your brain oriented to theory. To achieve the goal of reducing health disparities. So we've been talking about health disparities, the social determinants of health, health equity. We want to reduce health disparities, and to do that effectively, our public health programs and interventions must provide gains in improving health, reducing the risk of disease, and assisting with managing illnesses. Public health programming is most effective when we target multiple levels of the system. The individual, it's great when we do individual level programming, but if it's not supported at those larger, more complex levels, the behaviors that we are trying to change will not be sustainable. So this is why this is one of the reasons we use public health theory. So a quick definition of what theory is. If theory makes you nervous, I don't want it to make you nervous, but the big picture is a theory simply gives us a systematic way of understanding events or behaviors and or situations. So when we're using a theoretical framework in public health, we use it as researchers to better understand the disparities that we see, especially when we're working with culturally or ethnically diverse groups. We need to understand what are the things that are at play in the environment. Many of the common health behavior theories that we use in public health can be applied to diverse cultural and ethnic groups, allowing public health practitioners to really understand the audience, the populations that we're working with, the differential risks that are experienced for disease, and the opportunities for where health promotion will be most effective. Public health theories have shaped and defined our field. There's no one single theory or conceptual framework that dominates public health research or practice, but there are several key theoretical frameworks that have emerged and been used extensively in health behavior. So we'll talk about some of those, some of the most popular theories today. Theory, when we talk about it, it's a set of interrelated concepts or constructs that can be used to explain or predict phenomena. We use it to understand behaviors. We use it to explain behaviors. We use it to understand where the best place to intervene in a behavior pattern might be, and then to shape and frame our interventions and select methods that will be most effective in addressing a behavior. How does this happen? So we use it to explain and predict and pull apart these behaviors so we really understand what we're working with. We use it to develop inquiries, so surveys, instruments. We use the theory to test hypotheses around behaviors, what we think we see happening versus what's actually happening. And then again, we take that and we use it to develop our interventions. The one thing I will tell you before we move on is that you may use one theory to understand a behavior, or maybe you think that's the theory to use, and you maybe build a survey and you ask questions and you find out that that theory is not really helping you explain the behavior patterns you're seeing. So you might use another theory and that helps you, or you might use a combination of theories to understand a behavior, and you could possibly end up using a different theory altogether to design your intervention. It really is an iterative process that you have to go back into your data and understand what it's telling you before you can move forward. So we use theory extensively. And why do we do this? Just to refresh and kind of boil it down into basic. On our next slide, we have, there we go, public health approach and kind of our essential skills. So we are attempting to identify the risk factors. So if we find out that there's a problem that's leading to death or disability in a community, we need to know what the risk factors are. And so what we do when we use theory is we're attempting to paint a very clear and specific picture and find the key spot to intervene. So we have to understand the problem thoroughly, all of the risk factors and the things that either help or hinder the behavior, and then what can we do? Where can we intervene? Where can we, at what point is prevention going to be important? So we do like to, on the next slide is the social ecological model. Traditionally, in the field of health promotion, there was a really heavy focus on individual level factors such as knowledge, beliefs, and skills and attitudes for behavior change. But we know, and I've already said this once, that to be truly impactful and to make a change, we have to intervene on multiple levels of the social ecological model. So I start here. We have the individual, the interpersonal, the organizational, the community, and the policy levels. And the social ecological model was really developed to understand complex, multifaceted, and dynamic relationships between the individual and their environment and how it influences health behaviors and health outcomes. This originally came around in the 1970s. You don't need to know the history, but it was Yuri Bronfenbrenner, and it started with family systems research, so looking at families and the kind of complex interplay between an individual and their environment. And so we use the social ecological model to understand risk and protective factors and to address leverage points for our programs out in the community and for our policies. So if we seek to address obesity, for example, we have to look at various levels of influence that will impact the outcome. Physical activity is influenced by self-efficacy at the individual level, social support and the role of family and friends at the interpersonal level, perceptions of crime and safety that influence one's ability to exercise outside in the community. That's another level. And then workplaces and schools also have a role in this. So looking at, do the schools have recess? Do the schools have healthy options available? At the institutional and organizational levels, and also as the local, state, and national policies, how are they related to supporting good, healthy nutrition and healthy eating at the policy level, as well as physical activity? So I encourage you to think through the social ecological model and what does it mean on each level for a different health outcome or a health issue. And this will kind of help you think through, okay, where would be it most beneficial to intervene, but what would a multi-layered intervention look like? So on our next slide, we're going to jump into where our theories fall within the social ecological model. So we have some theories that really focus on the individual, and they're really helpful for understanding behaviors that are very individual or intrapersonal. So I think intrapersonal, it's like what's going on in your head, your knowledge, your attitudes, your skills, your beliefs, all of those things influence us and our behaviors and how we engage in health behaviors. So the first theory that we'll talk about is the Transtheoretical model. So when I asked you earlier, there was a question that I framed using the Transtheoretical model about where were you in your preparation for the CPH exam, trying to get an understanding of how soon are you taking it, how ready are you to take it, to help me as I talk to you about some of this information. This model was developed by Prochaska and DiClemente, and it basically posits that individuals move through 6 stages of change. And changes in health behaviors require multiple actions and adaptations over time, depending on what stage of change they're in. So we look at people as moving through behavior change, and they can either be not ready to, maybe they're thinking about it. So we have pre-contemplation, contemplation, determination or preparation, action, maintenance, and then we have this last stage where we have relapse and recycle. So pre-contemplation is when an individual has no intention of taking action now or in the foreseeable future. We kind of look in the next 6 months, they're not planning on making a change. And they're just kind of unaware and oblivious to the fact that their behaviors might have negative outcomes. Somebody who's in contemplation might intend to engage in a healthy behavior at some point in the foreseeable future, so we say within the next 6 months. And it's the big characterization is that they've come to the awareness that, oh my gosh, smoking is bad for me. So this particular model has been used quite extensively with smoking cessation. So just stop for some water there. So we know that they understand that this is maybe a dangerous behavior. When somebody is in the determination or preparation stage, they're ready to act. They plan to engage in the behavior within the next 30 days. And stage is really characterized by they're making small changes. They're doing the things and getting the little steps in place that will help support them when they do take action. So the action stage is when the individual has changed their behavior and they're within a 6-month time frame, and they plan to continue this new behavior change. When they move into maintenance, they have generally sustained the new behavior or have quit the old behavior. Like, so if it's smoking, they've quit smoking for over 6 months. And then when we get to relapse or recycle, is really about, from an intervention perspective, helping people understand what steps they can take to get back into action. So it's not about like, oh, you went back to smoking, you're done. It's about working with them to get them back to that stage of change. So on the next slide, so each theory has multiple constructs. So on this particular theory, stages of change is one construct, but we also have decisional balance and self-efficacy. So we talk about people are in a stage of change. So if you look across the top of the slide, you see those stages again: pre-contemplation, contemplation, preparation, action, and maintenance. But underneath them, you will see what we call this is also another construct, the processes of change. And those processes of change are what can help individuals move forward in their stage of change. So if we want to get people from pre-contemplation, meaning I'm not quitting smoking, I'm not even thinking about quitting smoking, I'm going to smoke until the cows come home, but we want to get them to the contemplation stage where they go, oh, maybe this isn't so good for me. We do that through things like consciousness raising, environmental reevaluation, dramatic relief, or social liberation. So each one of these processes of change can actually be operationalized into intervention methods that you would possibly use, for example, in a tobacco cessation program. We talk about decisional balance is really this construct of weighing the pros and cons, and really to get somebody to help them move forward in their stages of change. We want them to have more pros than cons. We want the benefits of quitting to outweigh the barriers. So what's in it for me? And it's got to be really important. And then self-efficacy, which is actually a theory on its own, but it is a construct you will see over and over again in the theories that we review, because it's so critically important. And it's the concept of self-efficacy is simply that a person feels capable of performing a behavior every single time they need to perform it, even when faced with barriers. So if I'm getting somebody to quit smoking, once they quit, they can stay quit even when they're in a difficult situation, every single time they're in that situation. So if they go out with friends, and that's a weakness for people who've been smoking, if they're around others who are smoking and drinking, and that's something they used to do, if they can stay away from the cigarettes while they're in that situation, they have very high self-efficacy. So we want to work to increase the levels of self-efficacy, and you'll see this in different ways, but some of the constructs under this theory itself are verbal persuasion, vicarious experience, mastery experience, and then there's a few other constructs, but mainly it's about someone's feeling capable of performing a behavior even in the face of barriers. And just, this is for your reference, so you'll have this in your slide deck, but these are the actual definitions for each of the processes of change. And as you read them, you can kind of get an idea of what would this look like in an intervention. So consciousness raising, often it's reading material or a short video or some information, statistics that are close to somebody's age, it's representative of their age and their experience, a model that they can relate to, that they say, oh, that person got lung cancer and they smoked as long as I did, they smoked the same cigarettes as me, maybe this isn't good. Or looking at the statistics of people their age who've been smoking. So that's just one example. So on your own, you can review some of these. They're very helpful in terms of deciding what methods you would use within an intervention that you develop. So our next theory that we'll talk about is the health belief model. And the health belief model theorizes that people's beliefs about whether or not they're at risk for disease or a health problem and their perceptions of the benefits of taking action to avoid it influence their readiness to take action. So this theory comes from the United States Public Health Service, and it was developed over the course of the 1950s. And it really came about when they were trying to understand why people would not take part in tuberculosis screening. And so here's an image of the x-rays were free to screen for TB, and people weren't coming out. We didn't understand what was going on here. And so they started to study the patterns of behaviors, and what they found was that if people didn't feel that they were susceptible or that the severity of the illness wasn't really bad to them for many different reasons, that they didn't feel at risk. They didn't feel threat. And so they were less likely to go get screened. And there's a few other constructs. So I'm going to show you the actual model now. Here it is. Is that it? That is it. Okay. So you see on the right-hand side, number 4 is the likelihood of behavior change. But if you go all the way over to the left, so the column on the right says likelihood of action, the center says modifying factors, and on the left is the individual perception. So this is, again, a theory that is oriented in the social ecological model at the individual level. And it's really about the idea of somebody's perception. So we think health belief model is related to individual perceptions, so your perception of susceptibility to disease and your perception of severity of the disease. So I personally had never felt susceptible to colorectal cancer, and my perception of the severity of the disease was pretty high because I know I've worked in cancer control and I know the statistics around colorectal cancer and the importance of screening. However, so I'm going to walk you through with this example, but my personal susceptibility was very low. Some of the modifying factors that increased my perceived threat of the disease, so if you look at the center, the perceived threat of the disease, age, I'm not old enough to even be screened for colorectal cancer. My ethnicity doesn't play a part in this. My personality, I'm in public health. Socioeconomics, I'm okay. My knowledge and my self-efficacy, I really didn't have anything going on there that would lead me to have an increased susceptibility. However, under cues to action at the bottom, my older sister was diagnosed with stage 4 colon cancer. And I'll give you, she's doing fine. She's doing amazingly well, and it's been 5 years. But I will tell you that that simple cue to action of somebody close to me being diagnosed increased my perceived susceptibility to disease like 100-fold. And my perception of threat went through the ceiling, and I scheduled myself for a colonoscopy within 2 weeks of her diagnosis because of our ages and of when she was likely first starting to have some of the issues that could have been prevented. And so we know that in order to get somebody to perceive the threat of disease, they have to have susceptibility, and they have to think that the disease is bad. I don't want this disease, right? Then we have cues to action. It can be people you know that get diagnosed. It can be education. It can be something you see on TV. It could be symptoms that you experience. And even with all of this at play, the health belief model posits that you still are not likely to change your behavior unless the benefits of the behavior change outweigh the barriers of the behavior change. So that's why under likelihood of action, you see perceived benefits of the behavior change minus the perceived barriers. And so these are the yellow boxes represent where we usually place our key interventions once we understand the behavior. And if this is a good model to use and the behavior is being explained by the health belief model, then we would likely use this to also guide the development of some components of our intervention. We want to raise susceptibility, the perception of susceptibility. We want to raise the perception of severity. We want to provide cues to action, and we want to increase self-efficacy. So for an example, I had the self-efficacy to know how to request a colonoscopy. Even though I know I wasn't of age, I knew to provide information about my sister's diagnosis, her age, her health history, and my own, which helped me schedule that appointment. And so we often see the health belief model used in addressing screening behaviors because we know how important screening can be. But it's used in many other health issues, but very often you will see health belief model applied to anything that relates to screening in terms of developing that intervention or understanding that screening behavior. And that's where it originated, so it makes sense. On the next slide, for behavior change to succeed according to the health belief model, we've kind of talked about this already, but I wanted to give you some actual constructs. So here are the constructs on the left. Here's how we define them in the center, and we've walked through those already. And then how do we apply this in action? So under perceived benefits, one's belief in the efficacy of the advised action to reduce risk or seriousness. And the application might be define the action that needs to be taken, or how, where, and when, and clarify what the positive effects are to be expected. So to continue with my example of a colonoscopy, while the barriers, a lot of people hate, they look at the colonoscopy process as horrifying, like, oh, I spend a whole day preparing for it. It's awful. I can't believe I have to do this. But the perceived benefit is you immediately have peace of mind, and that if you have polyps, they can be removed during the process and prevent future cancer occurrences. So we can really start to develop what are those positive effects that one would expect. So let's see. Now I've kind of walked you through these examples, but simply knowing the theories, that's really a good place to start. I always tell my students, you need to know these theories, you need to memorize these theories, but we really need to know how do we use these theories to explain, so explain and predict phenomena, and understand the behavior so that we can, going back to what we're trying to do here, is paint a very specific picture of the determinants of the problem. So we have to define the behavior very specifically. And we have to identify what the antecedents to the behavior are and the consequences for the behavior. What are those? And the skill here that I'm going to talk about is how do we use theory? We talked a little bit about the intervention side, but let's take a look at an example on the next slide. So in this example, this is a question that is used to understand behavior. And it illustrates that when we craft good questions, we get good information. If we craft okay questions, we're going to get okay information. So survey development is an important element for this. But specifically, what you see here, actually, I'm going to wait and let you think about what theory do you see in this particular question. And I'll let you take a second to think about what you think is going on here. And if you decided that this is a question that uses the Transtheoretical model, and it's attempting to identify where someone is in the stages of change regarding their physical activity, you are correct. Just to take a look at the question though. So it's a prompt. And the question or the prompt says regular exercise is any planned physical activity. Then it provides examples performed to increase physical fitness. Such activities should be performed 3 to 5 times per week for 20 to 60 minutes per session. And exercise does not have to be painful to be effective, but it should be done at a level that increases your breathing rate and causes you to break a sweat. So we give them some very specific information because we want them to answer as correctly and honestly as possible, because this is what helps us understand the behavior. Then we say, do you exercise regularly according to that definition? And if you look at the responses, what you see is a way that you operationalize the stages of change into question responses. So by asking this question to 200 people, we would be able to know which group is currently in contemplation, which group is in pre-contemplation, contemplation, preparation, action, or maintenance. And so working from the bottom up, you have the stages of change. If we don't write our questions very specifically, it will cause the data to become useless, and we won't really understand the behavior, or we'll misunderstand the behavior. Because everybody can define exercise very differently. But if we tell them exactly how we're defining it, then they're going to answer exactly what we're looking for. Not what we're looking for, but they're going to answer according to what we've provided. And that is helpful. So the next example, this is the development of a survey to understand vaccination for HPV. And so we actually have 2 different theories at play. So there's no questions for you to think about here, but this is really just for you to get an example in case you haven't done this or you're not as familiar with it. It gives you the theoretical construct on the left, and then the item, or what would be a true-false question on a survey, to understand why people aren't or are getting their child vaccinated for HPV. So if you look at perceived susceptibility, you know that's from the health belief model. And the question is, my child is very likely to get HPV, true or false? So you can see as you look through these, they're trying to understand what are some of the motivating factors, the behaviors that might lead someone to not get their child vaccinated or would lead them to get their child vaccinated. So it helps us understand as we try to tease apart, you know, why are vaccination rates where they should be when it comes to this vaccine that potentially will prevent cancer in the long run for these individuals. And we haven't talked about the theory of reasoned action, but we will very soon. It is actually on the next slide, one of our next theories to talk about. So when we look, so we've talked about some theories at the individual level, going back to the social ecological model. We're going to take a look at these 2 theories that are at the interpersonal level. The theory of planned behavior used to be referred to as the theory of reasoned action, and social cognitive theory. And the next slide is for the theory of planned behavior. So these are just some things to help get your mind oriented to what is this theory of planned behavior. It used to be called the theory of reasoned action. It was proposed in 1985. And really what it does is explain or predict how a behavior is formed. And really critical to this model is the concept or construct of behavioral intention, and the belief that behavioral intentions are influenced by the likelihood that the behavior will result in an expected outcome, as well as a subjective evaluation of the risks and benefits of such outcomes. So the one example on the right, gem stuff conveniently placed right next to my bed, is an indicator of behavioral intention. I am going to roll out of bed and throw on my exercise clothes, and then my intention is very high. The likelihood of me performing exercises is going to be pretty high because I got my clothes laid out, so the intention is present. This theory, the theory of planned behavior, posits that behavioral achievement is dependent both upon behavioral intention, which is like motivation, and behavioral control, So two important constructs. The model as a whole is composed of 6 constructs that represent an individual's control over a behavior. This includes attitude, so attitude about an act or the behavior, behavioral intention, so motivational factors that influence the behavior, and the stronger the intention to perform the behavior, the more likely the individual will actually perform the behavior. Subjective norm, which is factors around the individual, so this is that interpersonal element, social network, cultural norms, group beliefs, etc., and the individual's belief as to whether others will approve or disapprove of their behavior. So if my friends think it's great that I'm exercising, that's good. If my friends think it's a waste of time, then it might influence whether or not my intention is successful in leading to behavior. Social norms are considered what is normative in a group setting, and perceived power are the perceived factors that act as barriers or facilitators to the behavior. And then the last element is perceived behavioral control, which is an individual's belief of how easy or hard it is to adopt a certain behavior. So the theory of planned behavior has been used to predict health behaviors, including substance abuse, breastfeeding, and health services utilization, among many other things. Of course, it has limitations. It doesn't account for the environmental and economic influences that play a role in the adoption of health behaviors. So just to show you this as a model, as opposed to just images to get you thinking about your own behavioral intentions, this is where you can jot down some notes, but you can find the definitions of these constructs, and I have them on the next slide anyhow. But you can just, if you look up this model, you'll find all the definitions. But really what you see is in the blue is what used to be the theory of reasoned action. And what was added to make it the theory of planned behavior was this element of perceived behavioral control. And that's this built by the concept of beliefs, control beliefs, and perceived power. So if you work backwards from the behavior, you go to behavioral intention, and that is made up of attitude about the behavior, subjective norm, and perceived behavioral control. And then if you back up to attitude, to understand what builds one's attitude towards a behavior, we look at their behavioral beliefs and the evaluation of the behavioral outcomes. If I do the behavior, this is what happens, this is what I think other people think, etc. And then looking at subjective norm, it's built by normative beliefs and motivation to comply. And so on the next slide, it is just really for your reference, but it also provides an example of how you might understand, and sorry, it just didn't scan well. Back one more. So on the right-hand side, you actually have examples of how you might operationalize this theory into questions about smoking behaviors. So, and you can see that subjective norms and normative beliefs, if you look at how many of your friends smoke, and my friends would not approve of me smoking or not smoking, or my wife's opinions are important to me, and I can quit smoking if I try. So looking at that outside influence, that interpersonal influence on the behavior is important. On the next slide is yet another example of how you might operationalize this particular model. And on the right, you see what the outcome is sugar sweetened beverage consumption. So what are the behavioral intentions? And if you look, you can see how they collected data to address and develop this model. So I have made plans concerning when to limit my sugar sweetened beverages to less than 1 cup each day. And then the behavioral intention is I plan to limit my sugar sweetened beverages to less than 1 cup a day. And then you can back out to look at examples of what they actually asked in the survey to identify whether this model was accurately predicting and explaining sugar sweetened beverage consumption and intention to change. So then more specifically, I've got the actual questions here for you. It's like an interview guide actually, so you don't always do surveys, you might actually do interviews or focus groups using theories to frame your questions. So this gives you an example of how you might frame questions for a focus group or an individual interview to better understand the behavior. So you can just take a look at this or come back to it when you have time. And our next theory is social cognitive theory, which I think even people who aren't in public health have probably seen this if they've ever taken Psychology 101. And it's based off of Bandura's social learning theory. So Albert Bandura posited that learning occurs in a social context with a dynamic and reciprocal integration of the person, the environment, and the behavior. So what you see are clips from the Bobo doll experiment that Albert Bandura conducted when there was a lot of, and it's relevant today, especially this past week, that at the time TV, this makes me sound very old, but this is not from my time, TV was new and people were really worried that kids were going to do awful things because they watched Westerns or they watched cowboy movies on TV, and it was you know, the TVs were disseminating into households and people were able to afford them, and they were really concerned about the violence that children were seeing on TV. And this was the first experiment. It actually panned out that if you watched it on TV, it didn't mean you were going to do it in real life, but if you watched it in real life, you might actually perform the behavior. So it's really on this idea of watching others, so modeling, but it's not the only. So most people say social cognitive theory, modeling behavior, but it's not the only component. It's what it's known for. The idea is based on the belief that people learn through their own experiences, but also by observing the actions of others and the results of those actions. So in this particular experiment, they had the Bobo doll and the children would watch somebody beat the Bobo doll up, basically. They'd also watch it on TV, like a video of it. And they actually found that children were not as interested if they watched it on a video or on television. So on the next slide, we talk a little bit more about what are the constructs we use from this. So one of the constructs is called reciprocal determinism, and it is this interplay between the person, the environment, and the behavior, and that one impacts the other, and it can then impact the other, and so on and so forth. So it's very cyclical, and it goes back and forth is the best way to describe it. So, and within this model, we also have another construct called under cognition. So it's broken out into cognitions. So that's your next bullet. And we have behavioral capability, which is someone's ability or their belief in their ability to perform a behavior through essential knowledge and skills. We have expectancies. We have there it is again, self-efficacy. Like I said, we see it multiple times, outcome expectations and social influence. And then under observational learning, we have vicarious reinforcement. So watching others that are like us do something will increase the possibility that we might do something, and then modeling behavior. And then we have reinforcements that can be both positive and negative, and self-regulation, which is very unique to human beings, is our ability to self-regulate and set goals. Okay, let's see. And I think that's it for social cognitive theory. Okay, so moving on to the next level is Rogers' diffusion of innovations, or diffusion of innovations theory. You may have heard of, and to give you some definitions right off the bat, when we talk about diffusion, we talk about it being a process by which an innovation is communicated through channels. So the bolded words are important. We have different types of channels, communication channels, over time among the members of a social system. And when we talk about dissemination, it's a planned, systematic effort that's designed to make a program or innovation more widely available to a target audience or members of a social system. The critical idea is that behavior will change as innovations are adopted. So this theory was proposed by Everett Rogers. He's a communication theorist and sociologist back in the 90s. And it really explains how an idea, a behavior, a product really gains momentum and spreads through a population. And in public health, it's really about the adoption of new behaviors or beliefs or products, and that it's a process that takes time, as some people are more likely to adopt a new behavior before others. And this is really important because we have to understand our audiences that we work with when we're promoting a new behavior. And specifically, we talk about different categories of adopters. And this is also frequently used in the tech world and in industry when there's a new product, but we use it in public health all the time. So we talk about innovators, and those are the people who first try and adopt the new innovation. We have early adopters, and they're the ones who really embrace change, and they're typically the leaders who are aware of a need for change and comfortable with new ideas. And then we have our early majority, and those are the people who adopt new ideas before the late, technically it's the late majority after that. So we have the late majority, and those are the people who are kind of skeptical. They might have still been using flip phones when most people had smartphones. And then we have what is referred to as the laggards, and they're the individuals who are just completely skeptical of change and still buy track phones. So we use phones to talk about it because it's a relatively recent and very dramatic shift in the technology, but you can think about seatbelts as an example of an innovation and how long it took for people to adopt seatbelt use. When we also look at diffusions of innovations and what other things are important if we're using this to share an idea within public health and to specifically reach audiences to spread this idea and disseminate it, we need to think about the innovation itself. It's an idea, product, or process, the different communication channels that will help spread this, the time. So we talk about time as how long does it take for the innovation decision process to occur, and how quickly and how can we speed up the adoption of certain innovations? And then really, what's the social system like, the group in which the innovation is introduced? We look at characteristics of the innovation itself as well. Is it better than what was before, which is relative advantage? The compatibility, does it fit with our audience? Is it complex? Is it easy to use, or is it easier to use than what we've been using? And the trialability, can I test this out first before I make a decision to go forward and use this behavior or idea every single time? And can I see the results? Are they measurable, and are they visible? Something that I can say, yeah, you know what, I see that works, and I'm going to do it from now on. So I have an example for you of, it's been a while now since this was a thing. But when there was an emphasis from the CDC about sneezing in your elbow, and the focus was really on what I would say is like the toddler preschool age, and Sesame Street had multiple things about how to sneeze in your elbow, because sneezing in your elbow is better than sneezing in your hands, or using a tissue. So what was interesting was, there's also this news clip I've added of nothing to sneeze at. The reporter actually sneezed improperly during the press conference and was then subsequently scolded by the secretary at the time, Sebelius, and she was like, are you not watching Elmo sneeze in his elbow? It's really important. So the audience they targeted clearly, and this is something that's been written about, you can look it up, they really put this emphasis on young children, and young children are really, they've picked this up. They sneeze in their elbows, but adults it was a little bit slower in terms of the adoption, the innovation adoption decision process. On the next slide, I've already talked about these characteristics of individuals, but you'll see where they kind of fall out on a curve. And we have our innovators and our early adopters. Typically, we want to get to that 16% adoption rate, and that will help us kind of predict that this will be a successful dissemination of this new innovation. And there are features to consider. We use this to understand our audience, so to segment our audience. We'll look at who are our early adopters and what messages should we be developing for them related to the health behavior. We talk about the low-hanging fruit, who's most likely to adopt this behavior first and set the trend, because that will help speed up the dissemination and adoption. So that is the brief overview of diffusion of innovations theory, and now I have some more questions for you to see how closely you've been following along. And these questions will not have a poll with them, So you'll just be answering them. I'll give you what the right answer is. The first question is a health educator gives a presentation on distracted driving, and following her presentation, she discusses distracted driving with a student who just lost a loved one in a distracted driving crash. The student still texts and drives, but is asking for advice and assistance on how to change his behavior. According to the Transtheoretical model, the student is in what stage? If you answered B, preparation, that is correct. The student is ready to take action. This is characterized by her small steps toward behavior change, including sharing her story and asking for advice from the health educator. All right, our next question. On the next slide, let's see, question 7. So as the health educator engages students further, she finds that many students currently text while driving and do not see the relationship between texting and car crashes. For students at the pre-contemplation stage of change, the health educator would most likely attempt to A, encourage their behaviors and actions, B, develop cues that help to remind an individual not to use their phone while driving, C, share testimonials from those who have lost a loved one in the distracted driving event, or D, provide training and guidance to prevent relapse behavior. So the correct answer for this question is C. Individuals in the pre-contemplation state are still largely unaware or unwilling to admit that there is a problem. The first step is to attempt to increase their perceptions that texting and driving is a problem. One way that you might do this is to expose them to data and testimonials that highlight the issue. All right, the next question. Which of the following is a characteristic of a healthcare system based on social justice? I'm taking you way back to the beginning with this one. Is it A, a distribution of resources that removes human biases by allowing the market to decide how they are allocated? B, an individual's ability to pay is considered inconsequential to receiving medical care? C, a single-payer healthcare system? Or D, a system where the recipients of healthcare determine how resources should be allotted? The correct answer for this question is B. Ensuring that individuals receive care regardless of ability to pay is a central component of social justice. Other choices listed do not apply in terms of defining what social justice is. And our next question is our last question. Which of the following models explains the relationship between socioeconomic status and health by illustrating that health status and social standing are linked to a combination of interrelated social, cultural, psychological, and environmental factors? And from your answers below, you have Transtheoretical model, social learning model, social ecological model, or the theory of reasoned action. And the correct answer for this question is C, the social ecological model. It evaluates the interrelated set of factors that influence health and takes a systems approach to understanding factors that influence health. Therefore, this would be the correct answer. And that concludes my presentation for you today. And I think now is the time that we will see what questions you might have, and if we can address them now, we will, and if not, I will certainly be able to follow up with you via email.
Okay, thank you so much, Anna. I was just engaged and completely refreshed on everything having to do with health equity, social justice, and the application of theory. So thank you. Great examples and great way of explaining things. And for really putting it into context. We do have just a couple questions that have been submitted, and just to remind you again, to submit a question, just click on that orange arrow or the orange box with the white arrow. That'll open up your control panel, and then you can submit a question in the question dialog box, and we will answer any that are submitted. So let's see here. What is the difference between casual factors and determinants of health?
Causal factors.
Causal, yes, causal.
So causal factors are something we talk about when we're actually able to collect data that is around, what is it that causes disease specifically. It's causal factors are things that we would have to have a very high, well, it's hard to really have a definitive causal relationship. So when we talk about social determinants of health, we're talking about more environmental things that we've identified as influencers, where you work, where you live, if you live in a community that has high levels of crime, unsafe poor lighting, there's no sidewalks, or the light, there's a park, but a children's playground. So these are more environmental. When we talk about causal factors, we're looking more at the epidemiology of a disease. So that's where you'd see the term causal factors, causal relationships. So I could probably give you a better answer with more clear definitions via email.
Okay, great. You can send that to me, and then I can follow up with the group. There was a comment here, and it says, in TTM Construct 1, stages of change, the person does not have to start over from the beginning. They are typically starting from the contemplation or determination stage, from pre-contemplation stage, and are slips also common? So can you...
Okay, so is the question is if somebody makes it through a behavior change and they get to the end and they relapse, they don't go back to pre-contemplation. I don't know if that answers the question completely. But slips are, we get into kind of the technical side of the intervention itself on how you define slips. Some people slip and get right back to the behavior. And so it's how you define how one would respond and manage their behavior at that level. But once somebody is aware that a behavior is not healthy, or for like going back to smoking, so maybe somehow I've lived in a bubble and I did not know that smoking was bad for me. So I would be in pre-contemplation, but then somebody gives me a brochure that says, did you know smoking is bad for you? And here are the statistics that show. They can't go back to, you can't unknow that. So you know it, but you then make some conscious decisions. Clearly, there is the level of addiction that's involved. We know that nicotine and tobacco products are highly addictive. So it's then about building out the skills, the requisite skills one needs to manage slips when they occur. And that really comes, like I said, in the construction of the intervention itself and the design of a cessation program, for example.
Okay, great. Thank you for commenting on that. Sure. Another question is, what other theories are you recommending to review for the CPH exam, other than what you covered today?
I would personally, I think these are the major theories that one might take a look at. If you want to dive in a little deeper, I would recommend one of the texts that's pretty comprehensive is Health Behavior Theory. It's often referred to as the Glanz and Reimer textbook. So that's pretty comprehensive, probably more than one might need. I think the theories that I've covered today are pretty important. Maybe take a look at social network theory, I think is something that I feel is pretty important in terms of our work within the field of public health is understanding social networks. Off the top of my head, that would be the big one. Otherwise, I'd be happy to put together a list of kind of some other additional public health theories that we use frequently.
Great, thank you so much. Another question is, how do we deal with systematic problems to ensure health equity?
So, systematic problem. So, some of the things that I talked about really is how do we ensure that our programs are equitable, that they're reaching the people they need to reach, that we're also providing training, or what I call training up. So, the people who work in the systems. So when we talk about cultural competence and building out linguistically and culturally sensitive providers. And I also believe that one of the critical things is working with communities, not just in communities. So having communities where you're providing the opportunities and, you know, thinking about community-based prevention marketing or community-based participatory research, where communities are empowered to and given opportunities to develop the skills to address issues in their own communities. And so that's a critical piece of doing some of this work. But I think really it's keeping an eye on how do we change, how do we chip away at some of the issues that are tied to social justice. And that's really, you know, above social justice is looking at the social determinants of health. So how can we improve living conditions? How can we change the environment that people live in that are producing the health disparities? And we have to take a look at policy, and we have to think about this ties greatly to policy and having people who you know, everything from voting to advocacy efforts, all of that stuff comes into play in really making a difference. And it's hard. It's hard work.
Great, thank you so much. Another question, in your question about the TTM, you said that the answer was preparation. Why is it not contemplation?
Okay, I gotta go to that question. I want to say, without even seeing it, I think it has to do with the time. Let me get to preparation. Was this question at the very end?
They didn't indicate that, but while you're looking for it, there were a couple questions just about the slides and accessing the slides.
Sure.
So prior to the webinar, we did post them via Google Docs. Some people had problems accessing them via Google Docs, so I'll have our IT folks post them on a different platform, which may be more accessible. So we'll have the PDF presentation of the slides. Hopefully he can get those posted by tomorrow. There was a problem with posting the information from last week, and I know he was working on that, so hopefully everything will be posted by this Friday, and then from last week as well. And then let's see, somebody asked about continuing education credits for the CPH exam. If you participated today, you do not need a special code. You just simply indicate that in the self-reporting in the continuing education portal for the CPH. And then I don't know, somebody asked about taking the webinar prior to the webinars that are upcoming. We do not have those. Those are actually still in development. But if you do go on the NBPHE Study Resources page, you'll see that we have a wealth of previously presented webinars that you can access right now it's the way that the topics are, they're framed a little bit different, but all the information is the same. There's biostats, there's EPI, there's environmental health, social behavioral, so you can take a look at any of those and that'll have the same type of information we're covering. Let's see here. So you found the answer to that one?
I did. So it's preparation because it indicates that the student is still, so you are in preparation, you're still performing the negative, or I'll call it the negative behavior as opposed to the bad behavior or the unhealthy behavior. So the student, I'm assuming this is the one, the student's still texting and driving even after losing a loved one in a distracted driving crash, but is asking for advice and assistance in how to change these behaviors. So that is what indicates that they're in preparation, is that they're taking small steps to be ready for the change. Because once the person completely stops the behavior, then they're in action. In contemplation, they'd be thinking, but they wouldn't step outside of just, I'm thinking about it, but I'm not going to ask for help yet. So that is that definitive between contemplation and preparation, is that they're actually taking steps to prepare for a behavior change. I hope that helps clarify it.
Yes, the individual said thank you. She understands now.
Awesome.
Here's a question. Medical adherence is still a problem, for example, in HIV/AIDS patients, even with their knowledge and the need for adherence. How can we explain this and intervene?
Oh, there's so much research that's being done on this. And I think we still, despite all of the work, there's barriers that probably need to be, this is not my research area, so I'm just making hypothetical guesses here, but there are barriers that people face, and it varies, and so really understanding what the barriers are to medication adherence, but also maybe there's just, if there might be subgroups that have different reasons, but it would just be exploring that behavior a little more deeply. But I know there's people here at USF that are doing that work around medication adherence. So I think it'd be one of the things I would think is, like, let's look at what the barriers are and how can we lower those barriers, or is it access? I know the access has improved, but maybe that is still a barrier. But also when we look at social determinants of health, is there transportation? Is there public transportation? The list can go on and on. But I think that's where I would start, or, I would make some, but it's not my area, so I don't feel comfortable giving a great answer on that one.
Here is another commentary kind of question for you. In what ways can a public health professional keep social injustices on the larger cultural, national and global radar screen?
Advocate, advocate, advocate. And to the extent you are possible in your role, engaging in dialogue, engaging in respectful dialogue, I think is really important. I know some of the things we see things that I advocate for, I have to be very specific and in terms of my role working for a state university, but in my personal time, I'm a very big advocate. But I would say any opportunity you have is you have that conversation, even when I believe even if it's uncomfortable, but it opens the door for dialogue and respectful dialogue. That helps. Every tiny element of advocacy that you can do around our social injustices that are wreaking havoc in terms of health disparities and decreased health equity, I feel it is part of our role in public health to speak up.
Great, thank you. We had a couple of questions about the types of questions on the exam, and I'll comment on that in a minute. But is there any advice you want to give the folks that are listening today about the exam, about your topic, health equity, social justice, application of theory, that kind of thing for the exam?
What I would do is really, as you prepare for the exam, and this is just I give this advice to my students, I use this for myself if I have to prepare for an exam, is really to, one, recognize that it takes some time. And some of this time as you study and review material is literally sitting and thinking. So give yourself that time and don't feel like your time preparing involves actively writing or actively reading or typing up something, but actually thinking through a potential scenario. So that's why we had some of the questions today that was like a vignette, and then you had multiple questions. Take something that you're interested in, a topic, a public health issue, and then work through how might you address this. What's the role of social determinants of health in this issue? Where is the health inequity? How could you address health equity? And then maybe spend your time writing out your notes related to that. While the question might not be exactly the same as what you've written out to study and to think through, you can simply think, it'll give you that process of thinking through a question, applying a theory. So think about, how might I ask a question that uses self-efficacy or uses the health belief model to understand a health behavior, and see what you come up with. And so give yourself time. Don't pressure yourself to be like, okay, I'm gonna study for 5 minutes, 10 minutes. Give yourself that time, carve it out if you can, where you actually sit with this and do some thinking, which takes some focus, I know, because everybody is busy and distracted. But I feel like that's a really good way to prepare, because it'll get you ready for sitting in the exam and thinking through questions, and you'll have already done that. But try to apply, because I feel like that's an important element, is that the questions, not that I don't know what the questions look like, but the ability for you to apply what you know to different scenarios will be important.
Great, thank you. That was very helpful. I want to take just a minute. Let's see, I can go back and talk about the different study resources we had. Some people might have joined the call late. Right here, these are some resources that you can link to on the CPH study resources page on the nbphe.org. If you go to nbphe.org and click on Get Certified, you'll see the study resources link. You can view a link to the content outline and all the job tasks. You can see the sample exam questions, the practice exams. That is all free. The webinars that are being done currently, as well as the registration for future webinars, and then also the archived webinars that we have done over the past several years are all available there. The recorded presentations, we record each one, as well as post a PDF of the PowerPoint presentation so you can walk through at your own pace. We also have a link to the 2 paid resources, the ASPPH study guide, which is really study practice exams, where you go through and then you get a report on the questions that you got right, which ones you got wrong, and then it'll have a detailed explanation for every single question, as well as links to other resources that you can study. And then also a link to the APHA study guide, which these fabulous group of faculty from University of South Florida have developed, and that is purchased via APHA Press, and you can get that as an ebook, which you can just download to your computer, or you can get the actual printed and bound copy of that. So those are some resources for you. And then I did want to pull up our fabulous presenter's contact information, Anna Armstrong. If you have any questions, follow-up questions specifically for Anna, she has been kind enough to agree to answer questions that you can ask her, send them to her, and she'll answer. Or you can contact me. I'm Erin Williams, ewilliams@asppph.org. I am happy to answer any questions you may have. And then we should have this recorded presentation and the PowerPoint posted by Friday. That is what I've requested from our AT folks, and I hope they can get that up for us. We did have a problem with last week's, but I think they've remedied that, and those should be up ASAP as well. So thank you so much for joining us today. Thank you, Anna, for taking the time. We greatly, greatly appreciate it. And I hope that you all can join us for the next one. So have a great day. Bye-bye.
Bye-bye. Thank you.